multi-wavelength pattern scanning laser. I did my internship at LA County, USC, Los Angeles. And during that time, I did retina OCT research, volunteering work at USC Doheny Imaging Reading Center. Then I moved to Boston, where I did glaucoma research volunteering at Harvard University and the Mass Eye and Ear. And then I was appointed as the OCT Research Fellow, which is a pre-residency fellowship at the New England Eye Center and Tufts University in Boston. Then I was fortunate to do my ophthalmology residency at Yale University in New Haven, followed by surgical retina fellowship at the Retina Institute of California in Pasadena. And I'm currently attending an in vitro retinal surgery at the Retina Institute of California in Los Angeles and South Bay area. Just to have a quick outlining for our webinar, I'm going to start with an introduction, discuss some of the clinical background and information that are important when we're discussing laser treatment. And then we're going to discuss the benefits of different wavelengths and the clinical applications of laser, followed by multiple case reports of using the 577 nanometer laser, and also most recently the 561 nanometer laser. And we're going to finish with some conclusions at the end. So there are many retinal diseases that we use laser to treat, including diabetic retinopathy, retinal vein occlusion, even the complications of diabetic retinopathy like neovascular glaucoma secondary to retinal ischemia. Also, we use laser to treat retinal ischemia from many other etiologies. And of course, there's a laser retinopexy that we utilize in cases of retinal tears or breaks to create a barricade to prevent progression and into a retinal detachment. Diabetes is one of the leading causes of blindness worldwide, and since its introduction, laser has become a main stem or main tool in the armamentarium of treating diabetic retinopathy. Even recently, in the era of anti-VEGF treatment that has revolutionized the field of retina, it's amazing how laser still stands strong as an important tool that I utilize on a daily basis for my patients with diabetic retinopathy. Diabetic retinopathy can be classified as different stages. Non-proliferative diabetic retinopathy, where you can see multiple microaneurysms as a sign of retinal ischemia because of the diabetes affecting the endothelium of the small vessels within the retina. And odd exudates, macular edema, venous beading, cotton wool spots. And in more advanced cases, you can see the proliferation of abnormal vessels that grow because of the long-standing ischemia, where you have proliferative diabetic retinopathy and the complication of neovascularization within the disc or within the retina. These fonts of abnormal vessels can eventually ooze and bleed, and this bleeding can result in decreased vision, fibrosis, scarring, and eventually can result into tractional retinal detachment and complete vision loss. This is an example of tractional retinal detachment. This patient is lucky in a sense that it's not involving the center part of the macula, but it can certainly progress and detach the retina more as these scars fibrose and shrink and start pulling more on the retina. You can see on the top the multiple fonts of the neovascularization and the abnormal vessels. So the importance of laser treatment and wavelength information has become very important in the year, like the upcoming years after 2000. And this is a picture of conventional green laser, the 532 nanometer. You can see the laser scars in the periphery. This is a panretinal photocoagulation. And you can see that some of the scars are a little bit irregular because sometimes you can't get expansion of the laser scar, and then these laser scars can start touching each other. It's okay in the periphery, but it becomes more of a problem when you're treating macular problems. And these are some close-up photos of the laser scar by the 532 nanometer green laser. As I described before, you can see how the laser scars are expanding and almost touching to each other. But in reality, this was a great treatment for diabetic retinopathy, and it has saved vision in a lot of patients. This is a montage showing the different laser scars that are applied in the periphery 360 degrees. Also, there is the effect of retinopexy of the laser, where you see this patient with diabetic retinopathy who had panretinal photocoagulation 360 degrees, but eventually developed exudative retinal detachment in the periphery. But you can see how the retinal detachment is protected by the barricade laser that the patient had. So laser treatment has provided a salvage therapy for these patients with diabetic retinopathy to save them vision. However, when you look at this picture, there is no doubt that the patient is going to be losing quite a good amount of peripheral vision, and they will have scotomas or peripheral visual loss because of how heavy the laser treatment is in the periphery. So when it comes to the traditional green laser, the 532 nanometer, which has been the proven standard in photocoagulation since the introduction of laser in the 1960s, you can see on the graph of the wavelengths correlation with the absorption by the tissue that is highly absorbed by the melanin and it's well absorbed by hemoglobin, which means this laser will be absorbed by the melanin which is present in the retinal pigment epithelium and the choroid. So it will create some sort of RPE destruction, scarring, as well as it's absorbed by the hemoglobin, which is present in the microaneurysms, the leakage of which results in the macular edema. It has been a clinically proven asset to treat large variety of retinal diseases. The main clinical applications of green lasers are retinal photocoagulation in PRP for patients with diabetic retinopathy, or retinal ischemia from retinal vein occlusion. Also, we use it for laser retinopexy for patients with retinal tears, holes, detachments, and also in endophotocoagulation. Also, it has its applications in glaucoma treatment when we apply laser trabeculoplasty, and also the SP-Mode laser trabeculoplasty. I'm going to talk about the SP-Mode in the upcoming slides. I wanted to show this example of heavy macular laser that was done in the past. You can see here, there's no doubt that the patient has significant scotomas involving the periphery and the center part of their vision. I mean, maybe this was acceptable back in the 70s, 80s, but now we're in the year 2021, and the laser technology has revolutionized in a way that we can avoid these unhappy endings for these patients while providing them with the treatment necessary to save their vision. I wanted to show this example of a recent case I did for a neurosensory retinal transplantation where we borrowed a piece of the retina nasal to the nerve to fill in the defect or a macular hole in the center part of the macula. And with these new advances, you always think, do I want to burn the whole peripheral of the retina with heavy laser, or do I want to leave a triangle or a small area of viable tissue in case we need it for transplant in the future or for any other implications? Another important point that I wanted to discuss is the SP-Mode Microsecond Laser Technology that is available with the TruScan provided by LIGHTMED. On the top row, you can see the conventional continuous wave treatment, which is the conventional green laser treatment. You can see how every time you press on the pedal, You have the power the whole time that the laser is on. And then with time, you see the temperature build up, which results at some point in the temperature rising 20 to 30 degrees Celsius above the normal body temperature of 36. This results in a laser burn in the center part of the laser treatment. However, the periphery of this area, you can see the yellow color where you can see just like little sign of the laser. However, with the SP-Mode Microsecond Laser Technology, when you apply the laser, it applies on and off. So it leaves some time for the tissues to recover from the heat wave of the laser. And when you look at the time with temperature graph, you can see the rise in the temperature, which is much less when you compare it to the continuous mode on the laser. And you don't reach that red zone where the temperature is significantly elevated by 20 or 30 degrees above the normal body temperature. And this way you don't see a visible burn caused by the laser. The other issue that I want to discuss about the LIGHTMED TruScan is the wavelength, multiple wavelength that you can achieve, you can have for your patients, including the yellow 577 nanometer laser and the 561 nanometer laser. This is one of my favorite graphs because it shows you the wavelengths of the 532, the green traditional laser, and it shows you also the 561 and the 577 nanometer laser, which is the yellow laser. You can see how the yellow laser is like comparably absorbed by the melanin, which is naturally present in the RPE and the choroid, but it's less absorption by the melanin when you compare it to the green laser on the graph. The yellow laser does have a peak absorption by oxyhemoglobin, which is present in the microaneurysms, the leakage of which results in worsening of macular edema. And it does have a negligible absorption by the xanthophyll pigments, which are the protective pigment within the macula. You can see that there is some sort of absorption by the green laser, however, from the green laser by the xanthophyll, however, negligible absorption by the yellow laser, which makes the yellow laser very useful in treating large variety of retinal disorders, specifically disorders that are affecting the macula. So the yellow laser has been applied in pararetinal photocoagulation for diabetic retinopathy or vein occlusion. I've been using it successfully in treating retinal tears and breaks to create a laser retinopexy barricade. It has been used in endophotocoagulation and of course in treating diabetic macular edema, where you treat the macular pathology applying the focal laser using the yellow wavelengths. Coupled with the SP-Mode Microsecond technology, where you have the power applied only 5% or 7.5% of the time when the laser is on. And this has also proven as a good modality to treat central serous chorioretinopathy cases that are refractory to treatment with eplerenone or other modalities. Also, yellow laser has been utilized in glaucoma cases with laser trabeculoplasty and SP-Mode laser trabeculoplasty. So why is it important to achieve selective tissue targeting? First of all, you want to spare the macular protective pigment, the xanthophyll, and you want to target the RPE and choroid melanin without destroying the actual RPE. So basically, you want to stimulate the RPE, but not cause destruction to the tissue. And of course, you want to target the hemoglobin that is present in the microaneurysms, the leakage of which feeds into the macular edema. So this is just a quick graph to show the visible light spectrum. You can see the visible light spectrum extends between 380 and 770. And you can see that the green laser is around 532 nanometer, and adjacent to it, you can see the yellow wavelengths. And of interest here is the 577 and the 561 nanometer yellow laser wavelengths that I have been using to treat many patients with macular pathologies. So again, just a quick repeat of this graph where you can see the peak of the absorption by the oxyhemoglobin when you look at the yellow laser wavelengths, the 561 and the 577. And you can see how it's sparing the xanthophyll, which is a protective pigment within the macula. So it's easier to focus on the microaneurysm when there is significant edema when you are using the yellow laser, because of this peak of absorption by the oxyhemoglobin. And usually these microaneurysms are in the inner layers of the retina. And that keeps you away from the RPE and far away from the photoreceptors. Therefore, it's a safer treatment option for the maculum, and it targets the area that needs treatment without causing retinal damage. This is just a quick graph showing the carotenoids and the protective pigment within the macula. So these xanthophyll are mainly present in the outer plexiform layer. I just put this OCT to show where the outer plexiform layer is. And basically they absorb the light laser only minimally or negligibly. That's why treatment near the fovea is relatively safe using the yellow laser. We've published a paper back in 2009 or 2010 about the relationship between optical coherence tomography, retinal parameters, and visual acuity in diabetic macular edema. And one of the strongest correlations we found was between the photoreceptor outer segment thickness and visual acuity in these patients with diabetic macular edema. And this makes sense. Also, we found a significant correlation between the inner segment, outer segment of the photoreceptors integrity and the visual acuity in these patients with diabetic macular edema. Therefore, yellow laser is important in treating macular edema patients while saving or avoiding damage or destruction to the photoreceptors or the photoreceptor outer segment, inner segment zone. So if we use a 532 nanometer grain laser, we should use an injection of anti-VEGF or corticosteroids to reduce the swelling, so we're able to get to the tissue of interest when we use the green laser. However, the advantage of the 577 nanometer yellow laser or the 561 nanometer yellow laser is you can use the laser first when there's significant macular edema, because usually microaneurysms are quite superficial, and their oxyhemoglobin within these microaneurysms is going to be absorbed well by the yellow laser, which will help speeding up the improvement in the macular edema. Just showing the TruScan Pro, which has the capability of applying pattern scanning photocoagulation with the SP-Mode. So the pattern scan means that you can apply multiple spots of laser at the same time, and you have different grids and different patterns depending on the area of interest that you're treating within the retina. And also the SP-Mode technology, where you have the microsecond technology to have on and off treatment mode for patients with macular pathologies. These are some of the patterns that the TruScan can provide. Basically square, 3x3 or 4x4, depending on the areas that you're treating. Circle if you have a retinal break and you want to circle around it with laser. And of course a straight or triple curve. So the advantages of pattern scan laser are basically to improve the flow of practice. When you have a patient that you need to apply panretinal photocoagulation 360 degrees in a patient with significant high-risk progressive diabetic retinopathy, it's easier to do it when you have a grid of 4x4 or 5x5 or 3x3. Then you can treat large areas of the retina periphery in a shorter treatment session. And this is more comfortable for the patients, and it has proven to be very safe and very tolerable. We did a review paper comparing the pan-retinal photocoagulation for PDR using the pattern scan laser versus the argon laser. And from reviewing of the literature, it has been shown that the two treatments are comparable in regards to achieving regression of the PDR in these patients. You might have to do more session with the pattern scan laser in some of those papers, but it's okay, because I'm always a big believer that when it comes to laser, you can always add more if necessary. But if you create a laser burn or destruction to the tissue, you cannot reverse that. These are some pictures for pattern scan laser scars. You can see how the laser scars are kind of aligned regularly in the pattern that is consistent with probably 3x3 pattern that was used to treat these patients. And here you can see a combination of both the pattern scan laser on the bottom and the traditional laser scars a little bit more closer to the center. And you can see how the laser scars from the traditional laser, they can expand, they're irregular, they can start touching each other as they're expanding, whereas the laser scars from the pattern scan are more aligned and regular. The histopathology section in the central part of the macula within the fovea, that is showing the effects of laser burn on the tissues. You can see interruption and destruction of the retinal pigment epithelium in the middle of the graph, which is consistent with damage to these cells caused by the laser. And also you can see loss of the photoreceptors that are dependent on these retinal pigment epithelium cells. And there is no doubt that these are going to leave decreased vision, especially that these treatments are within the central part of the fovea or the macula. Also, this is a good graph to show how the melanin is present in heavy concentration within the choroid, which is to your left, and also the RPE, which is the layer of cells that separates the choroid from the retina. So I want to go over a few case reports from my experience using the TruScan laser. And the question that I want to answer in this part of the presentations are, does the yellow wavelength 577 nanometer or 561 nanometer work? And when should you try to use it as your initial treatment? Is the microsecond technology effective? And is it safe for central macular edema treatment? And once you encounter a response with the treatment with the 577 or 561, is there an additive effect of you repeat the treatment again? And could these laser treatment be used as adjunctive therapy in combination with anti-VEGF intravitreal injections? This is a 71-year-old African-American woman who has moderate to severe non-proliferative diabetic retinopathy with diabetic macular edema in the right eye. Her vision was counting fingers. You can see the significant macular edema with cystoid formation and the exudates. And on the FA, you see the areas of the ischemia and capillary non-perfusion, the microaneurysms, and enlargement of the foveal avascular zone. What I noted in this patient is that she had significant large cop to disc ratio or significant optic nerve cupping. And when I talked to her about the different treatment options, including the anti-VEGF intravitreal injections that need to be repeated every 4 weeks with this amount of macular edema, and the laser treatment, and with the recent evidence of some possible effect of anti-vascular endothelial growth factor or anti-VEGF injections that can result in transient elevation in the intraocular pressure and possible progression of glaucoma in patients who have susceptible nerves. The mechanism of this possible anti-VEGF optic neuropathy is possibly related to transient intraocular pressure elevation that can happen right after you do the injection. And we've proven in our clinic that we've done a study where we measure the intraocular pressure within 20 minutes after the intraocular injections. And we found significant intraocular pressure elevation in these patients, in some patients after the intraocular injections. And this can be detrimental in patients who have susceptible nerves or who are like glaucoma suspect, or they already have early signs of glaucoma. This could be caused by the reduced facility of outflow, because when you do these injections of anti-VEGF, there is some silicone oil droplets that are on the inner lining of the syringe. And these, if they go through into the vitreous cavity, can interfere with optic nerve circulation, especially if they get like stuck in a specific house, and I will show an example of that. Also, the liquefaction of vitreous from repeated invasion of the vitreous bursa and oxidative stresses caused by the multiple injections. Remember, these intravitreal anti-VEGF injections have to be repeated every 4 or 6 weeks. And so some patients receive it like 10 to 12 times per year. And of course, there's a vascular compromise caused by blocking of the VEGF pathways, because these are all anti-VEGF agents. And most importantly, is susceptible optic nerves, as some optic nerves are more prone to develop progression with any fluctuation in the intraocular pressure. This is an example of a patient of mine that I injected with anti-VEGF, and you can see the silicone oil droplet that got stuck in the optic nerve head, probably the jet of the injection and the silicone oil that is present in most of the syringes inner lining. So this silicone oil droplet got stuck in the optic nerve head for about at least 2 months. I mean, this patient was lucky that it moved away after that. And when it got stuck in that location, it's present in the blind spot that is associated with the position of the optic nerve. So it was not visually detrimental. But this is something also to think about. I have some other patients who tells me that they can see this silicone oil droplets because it usually floats within the superior vitreous cavity, and some sensitive patients are bothered by it. So going back to my patients, I discussed with her the treatment options, and we decided to go by the laser treatment for the macula using the 577 nanometer laser. And for her, I applied 100 microns for the spot size with a power of 120 milliwatt, duration of 100 milliseconds. And she was one of the early patients that I treated, so I just did traditional focal laser 85 spots. I didn't do the SP-Mode on her. Her vision significantly improved from counting fingers to 2400, and she was satisfied with the outcome. You can see anatomically how the swelling of the macula has significantly improved, and her vision actually improved as well. When we go to the thickness map of the macula utilizing the OCT, you can see the drop in the central macular thickness of 85 microns after 1 session of treatment with the laser. And also you can see significant drop of the thickness of the macula within the different quadrants and octants of this map. So case 2, a 50-year-old man with severe non-proliferative diabetic retinopathy with diabetic macular edema in both eyes, who has had multiple injections with Avastin. His last Avastin injection was about 2 months prior, and his vision in the left eye was 20/50. So you can see the OCT where the patient has significant cystoid macular edema involving the central part of the macula. The fluorescein angiogram on the right is showing multiple microaneurysms and like areas of ischemia and leakage within the macula, consistent with the macular edema that the patient has. So in this patient, I applied the focal laser using the 577 nanometer laser SP-Mode Microsecond technology, where I use the power of 110 milliwatt with a spot size of 100 microns, a duration of 100 milliseconds, and the total shot that we use 207 shots of SP-Mode, where we use the microsecond technology 5%, which means when you apply the pedal, the laser is on only 5% of the treatment cycle. Within 4 weeks, the swelling improved and the vision improved by 1 line from 2050 to 2040 in this left eye. And again, this is the map of the thickness of the macula, where it shows significant decrease in the central macular thickness after this session of treatment. So just to look at the map, when you see the white is a significantly elevated thickness. When you go to the red, you go into a less elevated. So you can see on the map below how it turned from white into the reddish zone. So case 3 is a 72-year-old Asian man with history of anterior chamber intraocular lens after a dropped sulcus intraocular lens. So he had basically a complicated cataract surgery, and they had to put the lens in the front chamber of the eye. And on top of that, he did have moderate non-proliferative diabetic retinopathy with diabetic macular edema in the right eye that he has received intravitreal injection with Avastin 2 times. And his vision was 20/50 in the right eye. So he also received laser treatment with a 577 nanometer laser for the diabetic macular edema, the power of 110 milliwatt with a spot size of 100 microns and the duration of 100 milliseconds. Initially, I did 19 spots of focal laser, and this is sometimes what I use because I like to test the power of the laser just a little bit away from the central part of the macula. And this gives you a good way to gauge the power that you're going to use for your central macular treatment. So basically, apply a couple of spots in the temporal side, maybe, or the superior or inferior side of the macula, and see how the focal laser is taking. And then you can stay with this power once you get a response. Switch to the SP mode 5% or 7.5%. and go with the SP mode safely to treat the central part of the macula. And this is what I did. So I applied 42 spots of the SP mode. The vision improved within 2 weeks from 20/50 to 20/40, and you can see the decrease in the thickness of the central macular swelling. And this was complemented afterwards with an intravitreal injection of Lucentis because the patient needed quick improvement in the visual acuity, and his vision eventually improved to 20/30 minus. Case 4 is a 56-year-old Hispanic man who was monocular. So basically, he had no vision in the right eye, and he had peripheral diabetic retinopathy with diabetic macular edema in the left eye, and he has had multiple anti-VEGF injections with Avastin and Lucentis, as well as panoramic photocoagulation treatment for the periphery, and the vision was 20/30 minus in that left eye, and this is the only seeing eye. When you think about the multiple injections, with every injection, there is a very tiny, small risk of endophthalmitis or infection in the eye. And this is a monocular patient who has only this eye that he can use to see. So he has had multiple injections, and his vision is still 20/30 with this, a little bit of off-center diabetic macular edema. So I decided to go with the laser treatment for him, and we did the 577 nanometer laser on him with a power of 120 milliwatts, spot size of 100 microns, duration of 100 milliseconds, and I also utilized the SP mode duty cycle of 5%, and we applied 70 spots on him. And actually, to have the SP mode and the 5% mode gave me an extra layer of comfort, especially treating this patient who was monocular. And his vision actually improved in the left eye from 20/30 minus to 20/25 within 4 weeks. And there was an anatomic improvement on the OCT as well. And this is the map of his macular thickness on the OCT, where you can see a good amount of decrease in the central macular thickness and the temporal macular edema after 1 session of treatment with the laser. Case 5 is a patient who had branch retinal vein occlusion with macular edema in the right eye after multiple injections of intravitreal Avastin. His vision in the right eye was counting fingers, and he had advanced cupping in the right eye. I put here in a picture of the OCT of the nerve fiber layer showing significant thinning of the nerve fiber layer within the nerve. And this is an FA showing the areas of ischemia and non-perfusion involving the supratemporal arcade and the temporal macula. You can see the vascular anastomosis, and you see the areas of leakage within the macula, consistent with the macular edema. So I gave the patient the first treatment with the 577 nanometer laser, a power of 100 to 120 milliwatt with a spot size of 100 microns and duration of 100 milliseconds, and I utilized the SP mode of 5%. I started testing with 10 spots of focal laser away from the central part of the macula, and then moved to the SP mode 5% and finished the treatment with 127 spots within the central part of the macula. The vision did improve within 6 weeks from counting fingers to 2400. Then I decided to do another treatment where we did similar modes for the laser, and the vision further improved from 2400 to 2200 within 2 weeks after the second session of the laser. I wanted to show this example to support the additive effect of repeating treatment when you want to get more control of the swelling. And when you look at the map of the OCT, map of the macular thickness, you can see gradual decrease in the center macular thickness, as well as the temporal macula thickening. You can see this island of red, which was hot or like elevated, is slowly fading away or getting less elevated and improving. And case 6, basically this is a patient that I applied the 577 nanometer yellow laser within the macula, and I did apply the pattern mode on the laser, of course using the SP mode as well. What I mean by that is we did the SP mode, which is 5%. That tells you that the laser is on 5% of the duty cycle. But on top of that, we did the pattern, which is 3x3, which means that you can apply 9 spots all at once. So that makes for a faster treatment when you're treating the macula. And honestly, I've treated the patient within a minute or two, finishing the whole macular grid or the whole macular treatment. In this patient, I also did test with laser shots in the periphery of the macula, like I did 10 focal, and then finished with the 127 SP mode 5% using the pattern. And the vision did improve from 2040 to 2025, and you can see on the pictures the gradual improvement in the macular edema in this patient. This is also an example of a patient that I treated with 577 nanometer laser. This patient has lattice degeneration in the periphery. If you look at the bottom part of the pictures, you can see these areas of thinning of the retina, and within it you can see some micro breaks, and also there's a little frank break in about 6 o'clock inferiorly. So this patient she was young, she presented with flashes of light, so this tells you that the gel is pulling on the retina in these areas where there is abnormal retinal thinning. So I recommend to do laser retinopexy, which means that you apply a barricade of laser around the areas of thinning and around the areas of the micro breaks. For this patient, I utilized a 577 nanometer laser, and I did the pattern 2x2 with a power of 220 milliwatt with a spot size of 200 microns and duration of 20 to 30 milliseconds. And we applied 137 spots. She tolerated the treatment beautifully, and you can see on the right the pictures of the laser scars after treating this area of lattice. And this is actually her other eye. You can see also the micro breaks surrounded by the laser retinopexy that was applied using the yellow wavelengths. Case 8 is a recent case that I did with a new laser that I had, 561 nanometer yellow laser. So remember, all the other cases we were talking about, the 577, this one was a 561 nanometer laser. This patient had severe non-proliferative diabetic retinopathy with persistent diabetic macular edema, who has had multiple injections of Avastin. So we use a 561, similar settings, 100 to 120 milliwatt for power, spot size of 100 microns, duration of 100 milliseconds. I did utilize the pattern 3x3, and I did the duty cycle, the SP-Mode duty cycle 5%. We did 10 shots of focal laser, followed by 127 shot 5%, and the vision improved from 2040 minus 2025 minus within 5 months after the treatment. And this is a map showing the decrease in the tender macular thickness on the OCT thickness map after this treatment. I wanted to play a video of this focal yellow laser 561 using the pattern of 3x3, which is applying pattern treatment with an coupled with SP-Mode, which means 5% that I utilized for this patient within the central part of the macula. You can see when you press on the paddle, 9 spots are being applied to the treatment, and you don't see laser burn, and this is what you want because you're treating within the central part of the macula. And you can see how I'm trying to target the areas where there are blood hemes or like areas of abnormal vasculature. I'm just going to play one more time. And actually, this treatment was for the patient that I just showed the case for on the 561 nanometer laser. So this is another case of lattice degeneration with a small break, and I also treated with laser retinopexy using the 561 nanometer laser. I applied the pattern 3x3. The power was 220, spot size 200, duration 20 to 30 milliseconds, and we utilized about 120 spots. So just to quick sum up of the SP-Mode Microsecond technology after we discussed the 577 and the 561, you can see how the delivery is in short bursts. The duty cycle can vary between 5 to 10%. I've had excellent results with 5% and 7.5%. I always tend to be more on the conservative side when we're treating within the macula. The beauty of the SP-Mode is you limit the heat buildup within the red pigment epithelium, the photoreceptors, and you eliminate destruction of the tissues when you're treating these patients with macular pathologies. And studies have shown fundus autofluorescence changes only with duty cycle of 15%, but I've seen no problems with the 5% to 7.5% duty cycle that I've been utilizing on my patients. It is very important to note that you have to use a smaller spot size when you're treating the macula. So basically you have to do 100 microns. This is what I do for all my patients for macular treatment. Remember, 100 microns is for macular treatment, however, 200 microns when you're treating within the periphery. So the advantage of the SP-Mode is stimulating the RPE healing after non-lethal injury and decreasing the amount of heat of the tissue that happens with the traditional laser treatment sessions. So this leads to stem cell migration to the injury site and preserve the inner blood barrier, and of course preservation of vision when you preserve the RPE and photoreceptors. So the clinical applications for the yellow 577 nanometer SP-Mode laser are retinal macular edema treatment, diabetic macular edema, retinal vein occlusion. I've also used it in some patients with central serous chororetinopathy who are refractive to eplerenone pills or other treatment modalities. And it can be used in many combination treatments. You can repeat the treatment session of the 577 or the 561 or both. And you can couple it with the anti-VEGF intravitreal injections. I've used it in many refractory cases that did not respond to intravitreal injections, and it was of great help for these patients. And you can certainly use it in treatment-naive patients as first-line treatment, especially if they have optic nerve pathology or optic nerve cupping, and you don't want to subject these patients to the variation of the intraocular pressure elevations after the multiple intravitreal injections. So just a quick summary for the settings that I use for the laser. For the PRP and laser retinopexy, I always go by spot size of 200 microns because you're treating in the periphery. The duration is 20 to 30 milliseconds, and the power ranges between 240 to 400 milliwatt. For focal laser and macular treatment, I always use a spot size of 100 microns and duration of 100 milliseconds with a power of 100 to 120 milliwatt. I gauge the power depending on my testing points with focal laser in the edges of the macula. And I like to use the SP mode when I'm treating within the central part of the macula. Gives me an extra layer of protection and relief. Usually I've had good response when I use this SP mode, and I had to utilize at least 100 to 150 spots. So in conclusion, yellow wavelengths 577 is effective in the treatment of macular edema and in pan-retinal photocoagulation and laser retinopexy. It's a viable initial treatment option in macular edema patients who have glaucoma or optic nerve issues. The SP mode is effective and safe in treating central macular edema. And when you encounter a response, there is an additive effect if you repeat the treatment again. And it's a great adjunctive therapy in combination with anti-VEGF and steroid in cases of recalcitrant or refractory macular edema. So the Vision of LIGHTMED focuses on customized wavelengths, efficacy, and extra layer of protection that provides the patient with excellent clinical outcome and comfortable treatment with no risk or negligible risk of complications. I've worked on the 532 nanometer, the 561, and 577. There are applications for the 670 nanometer red laser for patients with vitreous hemorrhage because it can penetrate through the vitreous hemorrhage to treat areas of ischemia. And there's also the 810 nanometer wavelength that is available with the TruScan Pro. I want to thank you all for your attention, and I'm happy to take any questions.
Okay, thank you so much, Dr. Alasil. That was a wonderful presentation. The images were beautiful. Thank you so much for sharing your cases with us. I do have some questions. Thank you. I do have some questions here from some of our attendees. And I apologize if there are some questions that may overlap or that you may need to repeat yourself, but feel free to go within to your presentation if you need to explain anything further. Okay, so here's some questions. So you did mention a lot about using yellow wavelength, and it seems like yellow has been your preference of wavelength, but you do use some green. Can you expand a little bit more about when is green might be better than yellow for certain applications and why?
I've been also using the green laser on the TruScan machine that I have. I would say green laser can be like maybe a comparable choice or even better when you're treating the periphery of the retina. Because when you're treating the periphery of the retina, even if you cause destruction of the RPE or the choroid, you actually want to create some scarring when you're doing, for example, laser retinopexy. You have a retinal break and you want to create a barricade of scarring around the break so fluid cannot go through the break and cause a retinal detachment. So in these cases, you can use a green laser, even if you create some sort of destruction or RPE destruction and scarring, because this is what you actually are trying to achieve as a prophylactic treatment to prevent retinal detachment in the future. And also in all my surgeries, the endo laser that we use during the endo laser with vitrectomy, it's all like green laser based. So we definitely use a green laser for that. Because when you have a retinal detachment or retinal break, you want more heavy laser that will target the outer retina rather than the inner retina. However, the scenario is totally different when you're looking at the macula, because with the macula, you want to protect or savor basically the outer retina and don't cause any destruction in the outer retinal tissues. So this has been my experience with the two wavelengths.
Perfect. Thank you so much for that explanation. I did mention to you that we do have a few different levels of participants today. Can you expand a little bit more about the difference between focal or grid macular treatment on retinopexy? What are those different applications? How are they different? Just a real quick explanation of each.
So basically, focal laser is the laser that you do when you have a patient with macular edema. Focal laser means that you're applying the laser within the center part of the macula, which is where your center vision is. And it gets tricky when you're treating in this area because you want to treat the swelling, but you don't want to cause destruction of the valuable photoreceptors that are present in this area, because they're in charge of your reading vision when you focus, when you do like the detailed visual activities. However, when you're talking about the laser retinopexy, it means that you're treating the periphery of the retina, or you have a retinal break and you're just trying to create a barricade of welding like destruction in the tissues. So that means what you're doing is creating a scar. So the retinal pigment epithelium is scarred. I mean, the retina is scarred down to the retinal pigment epithelium. So if fluid are able to go through the break, they cannot go through this area of scarring and further transition to cause a retinal detachment. So retinopexy is mainly what you do to treat retinal tears, breaks, or localized retinal detachment to surrounding with laser. However, focal laser is mainly applied within the center part of the macula when you have macular edema from different pathologies. So there are almost totally different treatments.
So in a focal laser, you would typically not see any scarring, is that correct?
In the past, when you did the 532 traditional green laser, there were cases where you had, and let me just go back to an example from an like image that I pulled from the literature, where they did a focal laser treatment, but in the past, I believe they didn't have the luxury of different wavelengths, and they just wanted to do any sort of treatment for the patient. Let me just go back to the slide here. When you look at this, this is definitely not acceptable in the year 2021, because you see the applied laser in the center part of the macula as if they were lasering in the far periphery of the retina. This patient will have a huge central scotoma on top of the peripheral scotomas caused by this heavy laser. So to answer your question, this is probably a laser applied in a retinopexy mode, or like within the central part of the macula. And this is definitely not what we're looking for in our current time, because we have like more targeted, smarter laser treatment where you can treat the pathology that you're trying to target without causing destruction of tissue.
Okay, thank you very much for explaining. That's helpful. So you did mention as well in some of your cases that you combine SP and focal. Is that correct? And at what point in time do you switch from focal to SP mode?
So recently what I've been doing is test with the focal laser and close to the arcades. Like put the, let's say I'm gonna go with a 100 micron spot size and 100 to 120 milliwatt of power. I don't like to do my first spot that I'm gonna test this laser on this specific patient, because different patients' retina are different. So laser is kind of an art. You have to find the perfect balance that you want to treat this specific patient, because different patients, they have different retinal thickening or different retinal capabilities of absorbing the tissue. For example, if you have a lightly pigmented patient, you might need more power for the laser to take, whereas if you have a darkly pigmented patient, you need less power for the laser to take. So I always like to gauge it along the arcade, which is away from the center part of the macula. So I do a few spots of the focal laser, and then I see, once I start seeing a response or like a tiny laser burn, what I do is I switch to the SP mode. And this way, I know that it will be safe when I treat within the center part of the macula, because instead of using 100% of the time the power of the laser, I'm using it 5% on the duty cycle, or 7.5% on the duty cycle. And still, I start making my way slowly towards the center part of the macula. So if I am start on the arcade with the focal laser, then I go to the SP mode, I start applying it perifoveally. And once I see that the treatment is all good, then I can target my treatment towards the central part of the macula. And once I know that the setting that I chose were safe for this patient, I have recently been switching also to the pattern scan, where I do 2x2 or 3x3 spots at the same time, because that will make my treatment much faster. And I usually finish these treatment within a minute or two maximum.
That's great to hear. It seems like it speeds it up very quickly, so that's nice. Do you also keep the power the same when you switch from focal to SP mode?
Most likely, yes. Once I see a tiny response on the focal, I keep the power the same, but I switch to the SP mode. And with the SP mode, I'm going down from 100% to 5% or 7.5%. So I've found it to be very safe technique. And on top of that, I make my way from the arcades slowly towards the center part of the macula. So I go parafoveally and then to the foveal center, if needed to treat in that area.
Okay, so I'm going to bring up some follow-up questions about SP mode since we're on this topic. You mentioned that you use 5% or 7.5. One of your last slides said about 10% to 15. Do you have any way of determining, or how do you determine whether or not to use 5, 10, 15, 7.5? Is there a huge difference? Can you elaborate a little bit more?
So I think from my slide, the 10 to 15%, this is something that I found in the literature, but myself, I like to use 5% to 7.5%, because for me, when you're treating the macula, I mean, probably less is more. I mean, if I feel like the first session of the treatment, I didn't get the full response that I was looking for, I can definitely add another treatment session. It's always better to do it in a safe way, because you want to preserve the patient's central vision. The slide that we have here, I don't want to see it, and it should not happen in our lifetime nowadays. So I found it safe to do 5 to 7.5%. It looks like from the literature they found some fundus autofluorescence changes, which are like microscopic changes on a specific type of pictures after the treatment when you use the 15% duty cycle. So when I saw that, I was like, I will try the 5 and 7.5%. I've not had any problems or complications with it. So for the time being, I think I like my settings. I mean, if I have a patient with huge, significant macular edema that I know it's not going to respond, I might go up to the 15% duty cycle. I have no problem with that, but there has to be a very legit reason to go up for me to the 15%.
So, I mean, for a lot of people maybe use SP mode or are newer to SP mode, and I've heard that there's questions about how do you know whether or not it's effective if you can't see the burn?
That's a great question. In the beginning, when I started using the SP mode, I was like, am I treating? Am I not treating? I mean, it was like a little bit in a shady zone. But when I saw the effects of the treatment for the patients in about 4 or 8 weeks, I mean, I was convinced that it works. And I think it never harms to try a couple of treatment sessions with the SP mode, 5 or 7.5%. Even when you don't see a laser burn, you don't want to see a laser burn in the central part of the macula. And just give it some time, like 3 to 4 weeks, and repeat the OCT picture using the progression mode on the Heidelberg. This is what I use, but I'm pretty sure all other machines can do that. So you can basically set the eye tracker so you're scanning exactly the same area, and then you can compare the anatomy and see if there is improvement in the retinal edema or decrease in the retinal swelling, and also do look at the thickness map on the OCT and see if the numbers are decreasing. And on top of that, ask the patient, have they noticed any change in their vision? Do they feel like they saw any better after the treatment? I actually have a lot of patients who sometimes I do both treatments, like one session I do laser and then the other session I do intravitreal injection. And then on some of the treatment session, I ask them, which treatment do you prefer? And actually a good percent of my patients, they prefer the laser, because just the idea of not putting a needle in their eye sounds more comforting for them, rather than, I mean, the laser treatment is very comfortable. I mean, you just have to put some numbing on the eye, put a contact lens, and do the treatment sessions. And when you have the pattern scan, you apply the treatment pretty fast, so the patients are not bothered by it.
That's wonderful to hear, because being a laser supplier, it's nice to hear that patients would prefer that. So thank you so much for sharing that. How long does it usually take for patients to see a difference in their vision?
I would say when we're talking focal laser or like SP-Mode treatment in the macula, at least a month or two.
Okay.
I've had patients who come after like 4 weeks and I see a minimal response, but then I wait 4 more weeks, which is like a total of 8 weeks after treatment, and then you see more improvement. So I would say sometimes you have to be a little bit patient and not rush into giving up on the treatment method that you've used, as long as the patient's vision is stable and they're not having worse complaints or worse like vision than the previous visits.
Would you recommend to anybody to, and I did see one of your slides that you did have 2 treatments. Can you repeat the SP mode again? And at what point in time do you feel that it would be appropriate to repeat the treatment again?
I've had multiple cases that I repeated the treatment. When let's say you have a patient with glaucoma or susceptible optic nerve, you did the first treatment, you got some improvement, you improved, let's say, from counting fingers to 2400. And the patient tolerated the treatment well, so let's say you gave it 4 to 8 weeks, but there's still some edema or swelling, so you can certainly repeat the treatment with the SP mode within 6 to 8 weeks after the first session, especially if this is a patient you think will have had like an initial reasonable response, or they have susceptible optic nerves, or they actually prefer the laser treatment over the intravitreal injections. Some patients, they are bothered by the burden of the injections every month, and they want to entertain other treatment modalities that can last them longer or maybe decrease the burden of the injections. So you can certainly utilize the laser as an adjunctive treatment in these cases as well.
How long do the SP laser or SP mode laser effects last?
That's a great question. I mean, in some cases, it can last for 3 to 4 months, but I've seen cases that after 3 to 4 months, they get recurrence of the swelling. Because remember, when you're doing these treatments, you're doing some sort of stimulation of the retinal pigment epithelium. You're trying to stimulate, I mean, you get some absorption by the oxyhemoglobin within the microaneurysm to decrease the leakage. But the diabetes or the retinal vein occlusion pathology is still there. So there has been damage to the endothelium of the capillaries within the retina. And this is not going to be cured by the laser. What we're doing with the laser is trying to slow down the leakage, stimulate the RPEs so they can pump more fluids out of the retina. So yeah, I mean, I would say in a few months, you might get recurrence of the swelling, and you might have to repeat the treatment with either laser or intravitreal injections or both.
Okay. Let's see. Okay, so you mentioned that you used 561. It looks like we have someone that's new to using 561 has used 577 in the past. What would you say to somebody who's just beginning to use the 561? Do you change your protocols from the 577, or do you approach it the same way as if you had the 577?
I would say start with a tiny bit lower power than what you use with the 577. For example, with the 532 laser, the traditional green laser, when I do PRP, panoramic photocoagulation periphery, I usually use power of 200 to 230, 240, and it works. With the yellow laser, because it has less absorption by the melanin, I've sometimes used, I start my power with 240. So rather than starting with 200, I start with 240. And I sometimes go up to 300 milliwatt on the power with the yellow laser. And still you get excellent results, no pain. But I would say the 561 probably is falling for me in between. So rather than starting with 200 milliwatt on the power or 240, I sometimes start with 220. And of course you have to gauge it per patient, because depending on the pigmentation within the retina, within the choroid, within the RPE, they have different absorption for a different take for the laser. So this is the first issue when you're treating with PRP. In regards to the focal laser treatment for diabetic macular edema, I actually use pretty much the same protocol that I use. I test with the focal laser points close to the arcades, then switch to the SP mode 5% or 7.5%, make my way to the central part macula if necessary. And I've been using the pattern mode on the 561 as well, with no issues.
Great, thank you. Looks like we have another question. I know you mentioned you didn't use the 670 or 810 with the TruScan. I don't know if you've had any experience in the past, but we do have a question, so you could just answer it the best you can. For ND or NPDR, non-prolific diabetic retinopathy, does 670 work better than 810? Do you use SP mode in 670?
Honestly, I've not used 670 wavelengths yet, but I'm definitely open to the idea. I know they use some of these wavelengths for retinopathy of prematurity, but I don't do neonatal ICU patients or like pediatric retina. But when you talk about 670, the red wavelengths, if you're trying to treat vitreous hemorrhage because it has a better penetrance through the vitreous hemorrhage to treat the areas, usually the view with vitreous hemorrhage for the retina is hazy. And honestly, in this case, I just take them for vitrectomy, because during the vitrectomy, I can just clean the blood and then apply in the laser for the coagulation. But I'm pretty sure it has its application and successes, but I haven't tried it myself.
So for NPDR, you recommend using yellow from your experience?
Yeah, I've been very comfortable with the yellow laser. Even I do like PRP for severe NPDR with high risk. I do PRP in the periphery with either 577 and 561, and I've had excellent results with it.
Okay, perfect. I'm going to switch gears and move to some pattern questions. Is there a laser scar after pattern laser expands?
That's a great question. It depends on the angle that you're applying the laser, because sometimes when you are reaching the periphery of the retina, the far periphery, and you must have like some sort of a tilt because you're trying to get to the view to the periphery with your contact lens that is pushing on the eye and indenting on the eye wall. So sometimes if the surface of the eye, of the retina, that is getting the laser in an oblique fashion, you might get uneven scars, even with the pattern scanning laser. But this can happen with all the machines, and you're treating in the periphery anyway. But usually within the mid periphery or the posterior pole, the laser scars that I've seen are usually even. And also there is always titration up and down on the power of the PRP laser. So as I said, I start with the yellow laser around 240, and with the 561 I start around 220, but then I adjust my power depending on the laser burns that I see. So remember, with PRP pattern, which means the pan-retinal photocoagulation in the periphery pattern laser, you will see a laser scar, and this is what you're looking for. You're trying to create some sort of like treatment in the periphery to kill the ischemic areas in the retina. This is different than focal laser when you're treating the macula itself. So you can titrate your power depending on the laser burn that you encounter initially. And what I like to do is don't put your pattern laser treatment like exactly next to each other. Leave some tiny space between them. And this way the treatment will look even organized, and you will avoid the risk of, like, if there is a laser scar expansion, laser scars touching each other. And most recently, if you have a patient who you think might have a macular hole, or they do have a macular hole, and you're not sure if vitrectomy with inner limited membrane peel alone will close the hole, I like to leave a triangle in the nasal periphery if possible without laser treatment, because you never know, you might need to borrow that piece of neurosensory retina and do a transplant to fill in the defect of the macular holes in some part of the macula in the future.
Okay, thank you so much. And to expand a little bit more on pattern, you mentioned that you use 2x2, 3x3 square, and a circle, right, for retinal pexy cases. How do you know what pattern to use and when? Do you have some kind of, can you elaborate a little bit more on that?
Usually the shape of the pathology or the architecture of pathology will dictate what treatment patterns, pattern you're going to be utilizing. Usually in the center part of the macula, I use the traditional grid, 3x3 or 2x2. It depends on how wide of an area of pathology that I want to. If it's like a big area of dot blot heme, I'll go with a 3x3 or even 4x4, because I know that I want to apply treatment in all these big areas of dot blot heme or swelling. However, if there are tiny microaneurysms that are far away from each other, then probably I will do either the focal or the pattern 2x2, because I want to localize treatment to that specific pathology. When we talk about the pattern that is circle for laser retinopexy, it depends on the size of the retinal break tear and whether they have a cup of subretinal fluid around the tear, and the size of the cup of retinal fluid around the tear, because if there's a large cup of fluid, probably you will need a larger circle. But even in these patients, I've been using sometimes the regular pattern where I use 3x3 or 4x4 and just apply it around the break, because sometimes it's very hard to get anterior to the break, to the very periphery. If the retinal break is way in the periphery, you're not going to be able to center your circle perfectly in the periphery. So I usually go with the pattern of 4x4 or 3x3 and make my way around the break and try to close on the break on the anterior edge. If you're not able to reach that very anterior edge of the break, then you can just create a triangle with laser scars to keep that break basically barricaded from the rest of the retina.
Okay, perfect. And it looks like questions are starting to slow down. I have one more. I think you've already mentioned this throughout your presentation, but if you could just mention it again, what are the advantages of the different or having multiple wavelengths?
I think it gives you an extra layer of protection and more capability to treat many different pathologies. I mean, I definitely utilize right now yellow laser with SP-Mode for all of my focal laser treatments, unless if it's a huge only solitary microaneurysm that I just want to target with a focal laser, traditional focal lasers, and I just do it. And also, the patient's tolerance is pretty good for these yellow wavelengths. No pain, no discomfort. They like the treatment. They go home. They just go back to whatever they were doing, and they can even, some of them, they even can go back to work after the treatment sessions. I think the pattern really helps you save time in the clinic. It improves the flow of your clinic. When you have a lot of patients waiting for you, and then you want to apply one PRP after another, like for the retinal periphery, it really helps when you have the pattern like 3x3 or 4x4, because then you can treat large areas of ischemic retina all at once and quickly and move to the next patient.
How
And
long
also,
does, I apologize. I was just wondering how long in comparison to a traditional single spot does it take?
I would say, I mean, with traditional PRP, I mean, you can do it in 4 to 5 minutes. Sometimes with old green laser that I've encountered in the past, sometimes it might take 7 to 10 minutes because even the optics on the old lasers are not the best. So you have to tilt your slit lamp microscope for the laser in order to get the perfect balance. And on top of that, you're applying single spots, so it will take you longer to treat a reasonable area of the peripheral retina that is ischemic.
Okay.